Sagar, who's next, or I have to present?
Dr. Dhananjay with his Impella.
Dhananjay is there, yes. Dhananjay is again a young, bright chap.
So, good morning, everyone. I am going to present a case which came to me in midnight, and she was 70, a female. Uh, she came with anterior valemi. Basically, her chest pain was of 4 hours. She was hypertensive, dyslipidemic, but non-diabetic. At presentation, her heart rate was 118 to 130 per minute. Systolic pressure was hardly 70 mmHg, and respiratory rate was quite high. She was maintaining saturation of 88 to 90% on full oxygen. Her echo was her ejection fraction was hardly 30%, and she had mild MR. So we immediately took her for a primary PCI. This was her angiography. Her LAD was thrombotically occluded from the proximal segment. The LCX was critically stenosed at the junction of OM, and the RCA was critically stenosed from mid part. So there was also one lesion in the proximal segment, osteoproximal segment of the LAD, but we in the midnight and in the cardiogenic shock, we had only support system IABP at that time. So I did angioplasty with the a smaller segment stented in the proximal to mid part, and then the initial outcome was good. There was good TIMI3 flow in the LAD, and we um, yeah, we stopped there on that day, and kept her in ICU. The chest pain subsided. The breathlessness was still there. She was on an IV support. She was maintaining BP of around 100 mmHg on IABP and moderate to high dosage of inotropes. The ST segment also settled. Echo remained the same, and somehow renal and hepatic function was normal. But even after 3 to 4 days, she was not maintaining BP, even on slight moderation of IABP, even 1 is to 2. So it was difficult to win it out. But in 3 to 4 days, she was exhausted and sleeping in single posture. So we decided to remove the IABP and put her on a high dose of inotropes. But in the next 2 to 3 days, even as a slight decrease in the inotropes, she was going in hypotension, and it was like a vicious cycle of decrease in inotropes, hypotension, then again high dose inotropes, and it happened for 3 to 4 days. After discussion with CTVS, they were not ready to took that patient to the operation theater because of the very high mortality risk, as well as the relatives were also not ready to take that risk. They were ready that what will happen here. So we discussed about the Impella supported complete revascularization, and finally they agreed to that. And now I started the Impella supported revascularization. I started with RCA, uh, revascularized the RCA, and then this was the RCA. It was a fibrocalcific lesion, although the calcium was around 180 degree, but it led to cutting balloon, and gave good outcome in the RCA. Then similarly on the Yeah, this was the final IBUS run of RCA. Then on the LCX was critically stenosed, as well as the anatomy. It was not supporting any hardware to go after the lesion. So I took one anchor ballooning on the previously stented LED segment, and thereafter all the hardwares went smoothly. We pre-dilated, and again this was fibrocalcific lesion. But it also yielded well on cutting balloons. And the good thing was that the osteoproximal 7 to 10 length of osteoproximal LCX was disease free, so I avoided stenting the LCX ostium. And put it the stent after the proximal to LCX to OM. And then this was the LCX final IA. Then I was imaging to the LED, and the LED stent was well opposed, although I had not post dilated that day, so there was a scope of some post dilatation. But the proximal most segment of the stent was on the plaque, and it was around 60% plaque. So the big issue was that, and then the osteoproximal segment again of the LED again had around 60 to 70% plaque with 20 to 30% of plaque at left main ostium. I initially um, decided to put a crossover stenting from left main to LED, but the left length of left main was around 8 to 9 mm, and the ostium of the left main was diseased for 1 to 2 mm also, and I had at that time the balloon of a smallest length of around 8 mm, so I had to go to LM ostium. So I after the post dilatation bed preparation, I gave one stent from left main ostium to LED with overlapping with the distal earlier stented segment, and after post dilatation and what the I was done was showing the well covered left main ostium. All stent states are well opposed and with good luminal gain. I kept the Impella for 12 to 14 hours, but in the morning, don't know, this was my first Impella case, and neither me nor my the cath lab or the nursing team was well versed with the Impella. So in the morning, the patient developed severe chest pain, and it was not coronary. The ECG was fine, everything was fine. It was like parietal pain, and even with the movement, slight movement of the patient, she was screaming like anything. So, and I don't have much experience of Impella, so I decided to remove it on that day. Although she was on a moderate dose of inotropes, it is not advisable to remove the Impella on the moderate dose of inotropes, but I decided to remove it. And thankfully, patient improved later on within 3 to 4 days. She was off inotropes in within 2 days. Her creatinine and everything improved. The patient discharged on fifth day, and now it is more than 8 months, and she is doing fine, doing in fact very good. Her LVEF has improved from 30% to 40%, and GLS around -6% to 11%. So this is how it
Thanks,
go.
Dhananjay.
Thank you, sir. Thank you, sir.
Thanks. It was again a very complex, challenging case.
Sir,
And I'm sure, here the Impala support was very handy. I
sir,
think that was a saving point for the patient because this patient, without mechanical circulatory support, it's very, very difficult to salvage such a subset of patients which is very down with hemodynamics.
sir. Thank you.
Uh, so well done overall, but yes, this is a point of discussion always when to take out the Impella. So that's what I'll present, and I'll show in my presentation. And I think Impella should be kept. One, continue to look at the LVEDP, which is again very easy to see with Impella catheters only. We can have LVEDP measurements. We can have a PA catheter to know the PA pressures. And if they are better after revascularization, you can take out after half an hour waiting or one
Marshall,
in
एक
the
मिनट
cath
कट
lab.
कर रहा हूँ.
Keeping a Impella, the system has to be in place. And I'm sure these people, the Viva people give us a lot of support. So they are very, very supportive. And then the system has to be geared up, because Impella shows some movement with the cardiac contractility. And the patient is also moving in ICU. So those things have to be there. If the parameters haven't improved after revascularization, it is worthwhile keeping an Impella overnight and keep checking the parameters. what is the other option? I'm coming with my presentation, but well done,
Thank you.
Dhananjay.
Thank you.
So keep it up. This is a
Thank
good
you so
work
much.
and keep up the good work.
Thank you.